So welcome to Transform Gov, where we share real-life stories on how technology and data are changing the way public services are designed, delivered and experienced. And in every episode, we go straight to the source, that is the leaders making the calls and the teams getting it done. Transform Gov is part of the Ireland eGovernment Awards and is brought to you in partnership with Accenture. And I'm Eve Nefsey. Just a quick, gentle reminder to check out the incredible lineup for our Leadership Summit, which is on the 24th of September this year. We'll be joined by Taoiseach and those leading Ireland's public sector digital transformation. Topics this year include how will AI impact on the public service? And separately, we'll look at the role of digital in delivering effectively the Irish Infrastructure Strategy Plan. You can find details of our speakers and, of course, tickets at digitalgovawards.com. So promo out of the way, be there. So today on Transform Gov, we're joined by Professor Derek O'Keefe, who's a consultant endocrinologist. I always struggle on that one. He's an engineer and founder of Hive Lab in Galway, where clinicians, engineers and researchers work together to solve healthcare problems. Derek, you're very welcome to Transform Gov.
Thank you.
Now, you described yourself as a physicianeer. I'm going to say it wrong. Physicianeer. Physicianeer, there we go. What does that actually mean?
So a physicianeer is somebody who's trained both in medicine, or to be a physician, and also in engineering. And it's a portmanteau of those words because the combination of both is very powerful, I think.
So why is it really powerful?
So technology, as this show is about, is a bigger part of all our lives, but especially in healthcare, more and more. And if you have expertise in both, you dissolve the interface between the two. And what I mean is that engineers are taught to be problem solving. They're very logical. They're always solutions orientated. And in medicine, there's just so many clinical problems. Now, there is a difference in that, engineers tend to be very black and white, and anyone who's in clinical practice knows it's a spectrum of color. But you can find a lot of problems at the bedside that if you have the engineering understanding, you can come up with real tangible solutions for. Not science fiction, but science fact. So it's a great combination of finding problems and then obviously having the solutions that are out there to fix them.
And I know, I've learned recently from some of the podcast interviews we've done that it's not that uncommon. It's becoming more prevalent, isn't it, that combination? So Dr. Tony Shannon from the OGCIO also has that combination of medicine and engineering. So has it become much bigger way? Is it more common?
It has. Yeah, it has for sure. So I think the first thing for the listeners to know is that, for example, in America, everybody has to do a degree before they do medicine. Medicine's grad school over there. You don't go in after high school. And so in my own personal journey, I had done engineering first. I started off with a degree in electronic engineering because I wanted to find out all about the digital world. Then I did a master's of computer engineering because I wanted to learn more about software, algorithms, AI. And then I did a PhD in biomedical engineering because I wanted to learn how to apply those tools to a real world problem. And I thought healthcare was very interesting. And then in my own journey, after my PhD, I got offered a postdoc at Harvard. And when I was there, that was a transformational moment for me because I worked with people there who had done engineering at MIT and then medicine at Harvard. They were part of what's called the Health Sciences Technology Program. And so I was surrounded by physicianeers. And they said to me at the time, your engineering knowledge is quite broad and detailed and good, but you really need to learn more about medicine. And I remember saying, wow, I'm 27, 28 years of age. I just finished my PhD.
Yeah, I thought I was there.
Yeah, exactly. Yeah, I thought I was at the top of the mountain. But as they say in Nepal, beyond mountains, there are mountains. And the big thing they said to me back then that I'll always remember is they said to me, look, stop talking about things and just do them. Yeah. We literally put it on the sneakers here. It says, just do it.
Yeah.
And so I did. I went back and I enrolled in medicine and did my medical training, both here in Ireland and then across the pond again at the Mayo Clinic in America, where I specialised in endocrinology.
Okay. I mean, an expensive journey, I would have thought.
A long journey. In fact, when I got my permanent job in Galway in 2018, my father cried. He was so happy I was finished college.
Rejoicing.
Yeah, it was great. And the job I have, I should say, is an academic consultant. So I'm 50% of the time in the hospital working as a physician. And then the other half of my time, I'm in the university as professor of medtech. And that combination is very powerful. I often describe that interdisciplinary skill set, be it engineering and medicine, or maybe a data science and medicine, or whatever your background is. The skill set is very interesting when you mix them because it's a bit like the comic books with Superman. So Superman was born on Krypton. He was called Kal-El. He was just a normal Kryptonian. That's the story in the books. But when he came to Earth, he became Superman because of our yellow sun. So that combination of a different background in a different environment made him a superhero.
I was so glad that we got Superman on Transform Gov. I never thought that'd be a fact.
There you go. And it's true for most backgrounds, whether it's journalism, arts, law, medicine, science, whatever it is. When you mix them, something unique emerges from the palette.
I think that's interesting in terms of technology. Slightly a segue now, but they're bringing in a lot more creative people, not necessarily just engineers, because that combination as well can be really powerful. So I suppose collaboration, of different mindsets is really the best kind of combination.
And that probably leads on to what I found in 2018 when I started working as a consultant, and we started to identify and come up with these ideas to be actioned. I needed to set up a lab where we could bring people together to innovate through collaboration. And so we set up the Hive, the Health Innovation via Engineering Lab. That was 2019. We set that up about 6 months after I started in the hospital. And it's innovation through collaboration. So the idea is just like one honeybee can't make enough honey to be meaningful. It has to collaborate. So in the Hive, we have biomedical engineers, we have educational psychologists, we have computer scientists, we have medics, we have all the spectrum of educational disciplines, because you need people to collaborate to build things bigger than themselves. And so that's been very useful.
And is the focus particularly around healthcare, solving healthcare problems?
Yeah, it is healthcare. Now, when I say healthcare, it's not just at the bedside healthcare. We're also interested in environmental healthcare, looking at microplastics. We're interested in the health of the planet. We've done work in the low Earth orbit. So we're interested in lots of aspects of healthcare.
And what kind of problems did you see coming up again and again that you said, right, these are particular ones we need to solve?
Yeah, so there is a few when you work in such a complex environment as a hospital. And I've been fortunate that I've worked in America, I've worked in Europe, and I've worked in the developing world in Africa and Asia. So you see healthcare different in different parts of the world. And I should mention that as well, that when I started in 2018 with the great training I got in clinical medicine, I realized again after about a year working as a consultant, there's a massive difference between medicine and the practice of medicine and healthcare. And so I decided actually to go back and do an MBA to understand healthcare as
You're
a
a
system.
sucker for punishment then.
Yeah, and my dad didn't cry that time because it was part-time. So, but it was really useful because straight away you see one of the big problems in the delivery of healthcare is actually the process.
Well, also there's the pull against each other, isn't there, where you see the administration, healthcare, and I suppose the more clinician side.
Yeah, and
there can be a lack of understanding.
It also depends on your ecosystem. So in America, a lot of it's private healthcare. In Europe, we have the public lens, which is a very noble way to practice medicine. And just the actual administration. I mean, most people who go into healthcare, by their nature, are very good-natured and they want to help other people, whether you're at the bedside or further back, towards the boardroom. But it's the fact that so many people trying to achieve the same outcome. Often the system is set up and, redundancy comes into the system and layers come into the system that shouldn't be there and need to be re-examined and pared back. I often meet my colleagues in industry through my role in medtech, and they talk about the biggest companies in Ireland, 10,000 staff being the IT companies or the medtech companies. I mean, the HSE has over 100,000 people in it. That's a large organization to run. And therefore, it is very important all the time to reassess, are you doing things the right way? And I think that's where the big wins come from.
Yeah, I suppose, it isn't easy to turn them around. But in terms of, innovation and engineers, clinicians, researchers, what happened when they work together? What do you begin to see?
I think you start to see like emergent behavior, things that you don't normally see. I think the first thing is just to have the humility to respect that everyone's background and their own color palette is different than yours. And everyone will bring something to the table, and to be open to it, to be open to changing your mind. You maybe have done something for 5 or 10 years. You've pushed through the barriers, as it were, but it works for you. And then someone else comes in and says, hey, there's another way of doing it that might make it easier. You have to be receptive to that. The other thing that's really important when you are doing these big collaborative projects is that you actually vocalize your thoughts and your ideas, because it's well said in MBA programs around the world that the most expensive real estate in planet Earth, any city in the world, Sydney, New York, London, is the graveyard, because it's full of people with $1 million ideas in their head. So you have to share your idea if you have an idea, and if it's a good enough idea, people will come with you to try and implement it. And I think that's really important. And also, if the idea isn't a good idea, it'll fail. And actually, that's okay as well, because failure isn't fatal. You learn your mistake and you move on and you try a new idea. And I think that's really important as well. Certainly in academia, we're taught that because, you spend a couple of months writing a grant for an interesting hypothesis you have. And even if you're a really good grant writer, your success rate might only be 1 in 5. So that means 4 times you've submitted a grant and you've been told no, it's not fundable in the current environment. And so you get used to rejection. And that's actually a good thing, I think. So I think that's a skill that that resilience we need to train people more.
And I suppose high achievers in education are not used to failing. So it's a very new thing for them to experience. So we should probably build into our education early failures, because it's something you just have to live with. So sorry, on that very deep point, I've got to take a very quick break. We are going to pause for a moment to have a message from a very important partner, which is Accenture.
Through the power of cloud, data and AI, Accenture is helping the public sector by blending human ingenuity, technology and a delivery-focused culture to turn their ambitions into action. Be ready for any challenge by adopting a continuous reinvention mindset to deliver human-centric services that adapt and grow with your needs. Contact the team at Accenture to find out more.
So we're back after a short break, and I'm here with Derek O'Keefe, and we've been talking about lots of things, but mostly about the kind of mix between engineering and I suppose medicine and the benefits you get from that. But I want to go back a tiny bit to Storm Ophelia. When that hit, it suddenly became obvious that healthcare access in rural Ireland was a real problem. So tell us a little bit about what happened.
So at the time of Storm Ophelia, it was very heavy rain for a couple of days, and I live in the city of Galway, so I was able to get to work in my car, and I went to my clinic. I have a clinic on a Tuesday morning, a big diabetes clinic, type 2 diabetes, and I would expect 50 to 60 patients at my clinic between 8 a.m. and 2 p.m. And when I got there was literally nobody in the waiting room. And I was speaking to my colleagues there, and they were saying to me, yeah, look, loads of people have started to ring in saying they can't make it in from County Galway, County Mayo, County Roscommon because they're flooded into their farm. And I was like, oh, wow, we need to reschedule, all these clinics and so on. Because this is 2019 BC, so before COVID. And at the time then, people also started to ring in to say, actually, Doc, I was supposed to come to the clinic this morning and get a renewed prescription to pick up my insulin. And I'm flooded in here for the last 3 or 4 days. And what will I do if my insulin runs out? And then I remember thinking, oh, wow, there isn't kind of a playbook for that, because insulin, if you need it for type 2 diabetes, or especially type 1 diabetes, it's a life-saving medicine. You need to take it or your sugar will go high. And so I thought, wow, what are we going to do here? And then I went and I read about it, as you do as an academic or a clinician. And I realized that actually in other times around the world, when there was kind of a environmental event, like for example, a storm, like Storm Katrina being the famous one, a lot of people unfortunately died when they couldn't get the healthcare to those people. You can't send a helicopter to everybody. So I thought about that, and luckily, the only thing we could do was look at the weather forecast and say, look, it looks like the storm is abating. Hopefully we'll get access in the next 2 or 3 days. You'll be able to get out of your farm and get to the pharmacy. And that's what actually happened. But I remember thinking at the time, we should, in 2019, be able to deliver medicines to people's houses with drones. Because at the time, you could buy drones in toy shops, And in theory, you could take an insulin pen and put it on a toy drone and fly it across your garden and say, oh, I delivered a medicine across my garden. But we were interested in the actual challenge of delivering something over the horizon, beyond visual line of sight. So we put a project together then 2018, 2019 to work with the IAA. And again, when we spoke to them for the first time, they hadn't...
To the Irish
Aviation Authority, sorry.
Yeah.
Because it's very important when you're doing a project like that, you have the regulations around airspace. And I'm a pilot myself, so I'm very aware of the airspace, controlled and uncontrolled airspace, and the importance of it and the regulations. You have the regulations around the pharmacy, the cold chain of delivery of medicines. That's very important. Does the medicine get altered if you don't have it in the right temperature box or the vibration of the drone and so on? And then you have the dispensing legislation and regulations about, there's a reason, for example, we don't have mail order medicines. Medicines can't come in your front door from an online retailer, because what happens if the wrong person opens it up and takes the medicine? So that's why you have to actually go to a pharmacy and get your medicines dispensed. That's the way it should be done, especially for higher danger medicines. And so we had to work in a very complex regulatory environment with all these different domains. So we brought all these people together, a hive as it were. That was one of our first big projects. We called it the diabetes drone. And when we started talking to people in the drone industry, they said to us, look, nobody flies things over the horizon with drones unless you're the military, they're not dropping medicines. And then we were like, well, this is a really good use of drones and drone technology. We think it's a great use case.
A problem worth solving, right?
Yeah, and so we did that. We got everyone together and we worked for over a year and a half to sort through everything. We also had to find a drone that could fly over the horizon, 200 kilometers there and back. And we found a great company in Germany at the time who had a long-range VTOL, vertical takeoff and landing drone. And we put the project together and we flew a drone as a test case, because Ophelia had finished, out to the Aran Islands and back, which is about 20, 25 kilometers off the shore. And that project, that story, the work that came out of it got worldwide attention. And actually our drone ended up in the London Museum of Science as an example for, humanitarian use of technology.
Yes, yes.
So it was a really, really great project to do, and it showed we could do it. And then the next question, obviously, everyone says is, so why aren't we doing it every day now? And that's a different story. That's making a business out of doing drones.
Yes, yes.
But
I think there were wider implications, which we'll probably deal with. By the way, we're going to have part 2 for this interview because it's just so much to talk about. But in terms of other things you've been involved in, I want to ask you about the smart stents. What is that actually?
Oh, yeah.
Involve?
So the Hive Lab, this is another story from the bedside. So unfortunately, as you get older, you collect diseases, just part of being a physical being in the environment we are. And one of those things that unfortunately people get, about 5% of people get AAAs. It's an aneurysm in their aorta, the main vessel in your body. And I had a patient about 15 years ago who came in one night, acute abdomen it's called. So they're in distress and all their vitals are dropping, and you're in the ED and you're trying to figure out, is this a medical or a surgical issue? You're down there with the teams. And this gentleman, it turns out that with his family there, that he had a AAA, he had one of these aneurysms. He'd had a repair of it. So they put in this stent called an EVAR, endovascular abdominal repair or aneurysm repair. And that was only a few months previous. So straight away we thought, okay, that's the most likely thing. There must be a problem with it. All these vitals are dropping. So the surgical team took him up to the OR, up to the theatre. They opened him, but unfortunately he didn't make it. And when I came back down to the ED with the family, we had to explain that unfortunately he didn't make it and he passed away. And I remember his wife saying to me, if only he had known it wasn't working, it was leaking, or that it wasn't working properly. And that planted a kind of an idea in my head. And you kind of go around collecting those ideas with your lenses in the hospital when you see these problems. And then when they set the Hive up, I thought this is a great opportunity to kind of bring all the people together, the experts in biomedical engineering and in materials and in anatomy and in vascular surgery and so on, cardiology, and create a digital stent, a stent that would tell you if it's blocking or if it's leaking. And that way then you could intervene earlier. Maybe your flow rate is 90% and then suddenly it drops to 60% over a couple of weeks. And therefore, to bring that person in earlier to do maybe more invasive testing like CT angios or to get it replaced. And so the idea is it's an actively monitored device rather than this random, one scan a year that you might get in a good healthcare centre. So
it sounds to me, though, we'll go back to that in a second, but it sounds to me that the fact that you're on the ground seeing real problems is vital for you then to be able to say, well, that's a problem that's real.
It's a problem worth solving. Exactly.
It's worth solving. And do you think that's key for any sort of? I mean, is that a requirement, for example, of your Hive? Do they have to be practitioners?
No. So again, the Hive is like lots of different skill sets, and it's just that some of the ideas from and we have so many ideas. We have more ideas than we have, opportunities for solutions. But the ideas that ultimately make it to the bench for us to start building something are the ones we've already kind of screened out. Like that AAA problem that I mentioned. A third of those stents that people get fail. And when they do fail, a third of them die. It's the only thing in medicine when I was reading about it called a ticking time bomb. So you're told you have
inside
this
you.
Aneurysm, which is obviously very worrying for you that you have this aneurysm that might pop like a balloon. Then you're told that you can get this stent to help you. And you're like, great, that's a great win. But then you're told, I'm sorry, a third of these will fail unexpectedly. And when they do fail, a third of them will be fatal. I mean, so it's the only thing that I ever read about in medicine called tick. So I thought that was a problem worth solving. Cardiovascular disease is a massive global problem. And so we went to put that team together with industry, with academia. We got great support from the medtech community to try and put the team together. And we got funding from Enterprise Ireland, the Disruptive Technology Innovation Fund, for about €6 million to develop that. And we're about, from an idea to an actual something you can take off the shelf is a 10-year journey. So we're about 2 years into that journey now. The funding is for 3 years. And the great news is the idea we had, because how do you measure flow rate in a tube in a body, basically? All the tubes to date, all the stents are just metal. So how do you measure flow? Normally you measure flow, as you know, for example, beside a mill and a river, it's like a paddle wheel. You can't use that in the body or it'll clot. So we came up with an innovative way to measure flow and then no batteries. So remotely then we can monitor it through different physics techniques. And so we had the idea, we did it in silica first, which is on a computer. Then we built the benchtop rig, and I got really great colleagues in engineering in Galway that have helped us on that journey, developing the sensor, developing the rigs. And we're at the point now where it's all working really well. So we're very excited about the technology. And because it's a platform technology, I mentioned that we're using it in cardiovascular disease. We can also use it, for example, in bladders to measure flow. We can use it in your lungs to measure your bronchial breathing. We can measure it in your brain for your VP shunts. There's just so many great applications for it that we're very excited about the future.
And it's preventative, right? Because it's preventative. And so the cost involved in not preventing is so high, not only in human life, but actually to the system.
Exactly. And that's a big mantra of the lab, as we'll talk about later. We're trying to change the lens from reactive healthcare, which is the way it's been for 2,000 years, to proactive healthcare. And the HSE itself is moving the lens, shifting left, trying to get people to be more healthy for longer before you get the blue light acute care. And that's very admirable.
And when you, just to go back to, I know that one of the challenges we've heard again and again could be getting things from the bench into pilot, then from the pilot into the actual system. So with the drone, for example, where you're delivering medicines by drone, is that now active in the system, or where is it at?
So good question. Yeah, so it's that one's still a pilot, and yes, you're right. So one of the problems with digital health in particular is that it has more pilots than Aer Lingus. It's a great idea. You pull
that one.
You pull people together and it works. But there's a difference between having a successful, prototype or pilot and having a viable business. So there's a couple of people around the world in the drone business. In Ireland, for example, there's a great company with Bobby Healy called Mana that's delivering, kind of coffee.
Based in Galway?
Based in Dublin, actually, originally. But he was in Galway on one of his early testings, and we worked with Bobby. And he's a great businessman, and he has the right skill set, again, to build a business from drones. And he's become like a world leader in drones, which is great to see for Irish industry. And so there is a business model there to deliver medicines by drone. And I guess they're just looking to get the right environment, regulatory, capital, and so on, that it actually happens. I mean, there's still challenges because we develop cities that are quite dense, obviously, with their structures, and also, like, drones work great in kind of suburbia where there's houses and you can fly above them and it's 2 stories maybe. When it's a skyscraper, not so much. And also just the regulatory flight paths. Like when we were trying to do it, for example, in Galway, because it's a Model 4 hospital, the helicopter lands there for the sea rescue, search and rescue, and we can't have drones flying in and out while a helicopter could come in, or you could have a major problem. So there's all those practical things again that you need to set up a drone base and then use that to as kind of an anchor point to fly out to the more lessly populated areas around the rural areas or the islands. And it's coming. It's coming for sure.
How far do you think before we start seeing it happening?
I'd say 2030.
Okay.
And that's been realistic. I mean, I could say, let's do it tomorrow and we buy a drone and fly it tomorrow. But there's a difference between a 3-year funded project to test something and evaluate it and make it a viable business. And that's why there's so much opportunity. And I think anyone that's in the space of drones welcomes other people to do it. Like, I'd welcome a company to do that. I've been in contact with a couple of them over the years who've asked for my opinion. Like the NHS are doing it successfully now, for example, in the islands off the south of England. They've made a business out of it and they're looking to get into other markets now. So we will see it for sure, yeah. And
what other projects are coming out of the Hive that we think you'd like to share with us? Because we're dying to find out what's coming down the track.
So there's a few other ones. So the one that we're very interested in is the use of robots in our world. So 10 years ago, you probably heard about a robot lawnmower. 5 years ago, maybe there was one in your village or town. 2 years ago, someone in your family got one. Maybe you have one now. There's kind of a slow rollout of robot lawnmowers. The big thing in the last 5 years has been the humanoid robots. You probably only ever saw them in theme parks 10, 20 years ago. Then they started to emerge in museums and in airports. And in our lab, we got one about 4 years ago during COVID, 5 years ago now, to remind people to wash their hands when they come into the hospital. It was a fascinating thing. That first wave of COVID in 2020, obviously we were all very busy at the front line in full PPE when we weren't sure the kill rate of COVID. If you remember when it first came out, we had those trucks in Bergamo, and we weren't sure, was it like Ebola where 50% of people have a bad outcome, or is it like more like the flu or something like that with 0.1% or 0.01%. And so we weren't sure, and so we were full PPE. And I remember coming down in one of my shifts to the front of the hospital to grab a drink out of a machine, and I saw people coming in very worried. At the time we had very limited access. You could only come in in ones and if you had somebody in extremis. And I just noticed that those people who were so distracted, they forgot to wash their hands on the way in, or maybe put on their mask until they were reminded later on in the hospital. And I thought, we should really have someone down there reminding people just gently to wash your hands, put on the mask, come into the hospital, rather than later on when they're walking up the corridor or something like that. And so I thought, that'd be a great use case for a robot. So at the time, the what's the word? The funding companies, they normally write 10, 20-page grants. At the time, they had like 5-page grants where you could write a grant very quickly with just the big ideas. So I wrote a 5-page grant that weekend saying it'd be a great idea to try a robot at the front of a hospital to see would it nudge people, digitally nudge them to improve their behavior. And so we did that, and we did a kind of a study, and I think it was like 50% of people were washing their hands coming in initially when we did the audit. And then we put the robot there, and when they walked in, the robot would just say, "Welcome to the hospital. Would you like to wash your hands?" And they all did it because all they needed was just a reminder. And so that was,
as you say, when you're in a panic or rush.
Yeah, it was a great use case for technology being additive to our lives. And then we took it from that, and we've done other projects with the robot in the clinics, and we've done a lot of STEM outreach. But last year we did an interesting one. We got a more advanced humanoid that actually walks, not just goes around on wheels. And we worked with Pieta, the fantastic mental health charity here, and we did the Darkness into Light walk in the Phoenix Park. So at 5 a.m. in the morning, you have about 10,000 volunteers, as you know. And one of those people that were there was the robot. We called it Project Tin Man because, like the Wizard of Oz, the Tin Man's looking for a heart. And we thought that's a great way to start a conversation about mental health and looking after yourself. So it was actually a great experience because myself and the team were there. We were walking. The robot was there, Deckard. And he was dressed, with a T-shirt and everything from Pieta. And people would be walking past going, "Oh my God, is that a robot?" Yeah. And then it would start that conversation. What's the robot for? And what's the project about? And that's really good. And they start telling people and taking. So I thought that was a very unique opportunity to bring science from the lab into the real world, as we'll call it. And for that conversation to start, allowing the robot to be the digital nudge to start the conversation. And actually, it's the first time a robot has ever raised money for humans. Okay. It was a sponsored walk, so that was a unique angle as well.
First. I don't know if you saw the Chinese robot dance competition.
I did, yeah, when they lose their control program, is it? And
exactly, a little bit of craziness going on.
Crazy breakdancing.
But some of them are really good. Actually, it's well worth watching it. I'm sure you can find it on YouTube.
Yeah, and just to say, I think those robots are going to be more and more in our lives.
Yes.
And I think that's just the horizon. Don't think it's going to happen in the next year or two, but over the next decade, it'll definitely, like that robot lawnmower, it'll be more common to have robots around us helping us.
Yeah, I think so. And I mean, look, there's lots of positives for robots in terms of language barriers, and they can learn really fast cultural norms. So, it's very exciting. But look, there's loads more to talk about. In particular, Derek has agreed to come back to do another interview because I want to talk about some real problems that you solved on the islands and then what's happened with that project. So in part 2, please come and listen to what Derek has to share with us about kind of scaling virtual care in particular, remote monitoring and future healthcare delivery in Ireland. And we'll explore AI and robots again, I think, as part of that. So you don't want to miss that. So if you found this conversation useful, please do share it with your colleagues. And if you'd like to hear more conversations just like this, you'll find them on our previous episodes, which you can find wherever you like to get your podcasts. Just before we finish, a reminder to check out our website for details of the Leadership Summit on the 24th of September, which is the morning of the Ireland eGovernment Awards. And you can find information at digitalgovawards.com. So finally, thank you to Derek, who's going to be coming back for part 2. And also a quick thank you to the studio. So studio manager Peter Rice, video editor Neil Horner, sound engineer Lee Brennan, and videographer, who's not here today, Richie Ryan. So Lee is doubling us both. And thanks for listening, and look forward to you joining us in part 2 of this episode.